Excellent. So we are all together.
Good evening. Добрий вечір всім. Добрий вечір, пані Оксана Збітнєва, пані Флоренс Аскіназі і пан Йорг Фегерт. Ми вас вітаємо з Києва, де все дуже непросто останнім часом. І пані Оксана це теж відчуває дуже добре. Ми дуже дякуємо всім, хто приєднався до нас цього вечора. Зараз я подивлюсь, що мені пише наша команда, скільки це людей в Zoom і скільки на інших площадках. Зараз чекаємо. Мені напишуть, скільки нас. Зараз одну хвильку. В нас вже 184 в Zoom. І зараз мені скажуть, скільки нас в YouTube. Мені здається, що для таких темних часів в Україні це дуже хороша історія. Нас люди прибувають в Zoom і в YouTube. І в Фейсбуці також зараз підключаються люди. І поки вони підключаються, я передаю слово пані Оксані Збітнєвій. Будь ласка, пані Оксана, представляйтесь і розпочинайте, як завжди.
Доброго вечора, учасники, партнери, друзі, неймовірна спікерка, яка приєдналася до нас цього вечора. Пані Катерина сказала про те, що темні часи, і так все непросто, але я неймовірно вдячна всім нашим учасникам, які в ці темні часи знаходять для себе цей наш майданчик, як майданчик світла, бо ви самі є тими, хто дарує світло людям. Неймовірні фахівці, які працюють в нереальних умовах, в нелюдських випробуваннях, віддаючи частинку себе тим, кому ви рятуєте, по суті, життя. За це вам от низький уклін і величезна вдячність. Сподіваюсь, що ви в безпеці. Сподіваюсь, що вам хоча б трошки тепло. І дай Боже, щоб у нас вистачило світла для того, щоб і інтернет був, щоб ми провели ці майже 2 години разом. Я нагадаю, що цей проєкт реалізується Координаційним центром з психічного здоров'я спільно з дитячим фондом ООН Юнісеф в Україні і в партнерстві з Європейським товариством дитячої та підліткової психіатрії. Професор Фегерт з нами зараз. Нашу підтримку цьому проєкту надають Міністерство охорони здоров'я України, Національна служба здоров'я України. Тобто ми ось так разом об'єдналися для того, щоб додавати знань і експертизи для фахівців, які працюють в спеціалізованих послугах для дітей і підлітків. Проєкт реалізується в межах Всеукраїнської програми ментального здоров'я та як ініціативи першої леді України Олени Зеленської. Тож бажаю нам сьогодні дуже натхненного вечора з новими відкриттями для вас. Дякую вам неймовірно, що ви, шановні учасники, завжди активні такі. Ми кожного разу аналізуємо кожний вебінар з пані Катериною, і кількість тих, хто приєднується, і кількість відгуків і запитань від вас є такими маркерами того, що все, що ми робимо з вами разом, воно є для чогось. Тож, гарного нам вечора, безпечного, насиченого і ще раз величезна вдячність учасникам і всім партнерам.
До того, як передати слово пану Йоргу Фегерту, дякую вам дуже, пані Оксана. Декілька організаційних питань. Ті, хто постійно дивляться, і так все це знають, але є люди, які вперше приєднались. І так, ви дивитесь цей вебінар в онлайні. В нас працюють перекладачі. Будь ласка, задавайте свої питання. Наприкінці ми всі питання зачитуємо. Не буває поганих питань. Всі питання хороші. Тому наприкінці я буду зачитувати всі питання, і спікерка буде на них відповідати. Як тільки цей ефір закінчиться, він вже є доступним на українській мові з перекладом. Потім він буде також доступний в оригіналі. Тому у вас буде 2 версії, так же, як весь час це було. І що ще хотіла сказати, що ми вам ще раз скажу дуже вдячні за те, що ви в такі темні часи, коли дуже холодно, сьогодні трішки тепліше в Києві, але загалом було дуже холодно весь цей час, і ви всі дуже замерзлі. І мені дивно, що в такі темні часи, коли нема світла і так холодно, ви всі є на цьому вебінарі, це страшенно приємно. Розповсюджуйте це для своїх колег, розповсюджуйте це для пацієнтів, це для нас дуже важливо. І наступне слово вступне до пана Йорга Фегерта, завдяки якому ми маємо загалом весь цей цикл вебінарів, за що ми йому страшенно вдячні кожен раз. Чи він є на ефірі, чи його нема, але ми завжди кажемо, що пан Йорг Фегерт – це наше все в темні часи.
Thank you very much. You are so kind. Thank you, Dr. Bulavinova. Thank you, Oksana Spitneva. It's really a pleasure working together with you and to see all your engagement and all the heart that you bring into this work. And it's a pleasure for me today to introduce to you our dear colleague, Florence Ashkenazi. She's professor of child and adolescent psychiatry and head of the child and adolescent psychiatry department and the Autism Resource Center of Nice in France, Nice Pediatric Hospital since September 2009. Her research subjects are post-traumatic stress disorder because she was at the edge when a terrible terrorist attack with a big car happened just in front, just near to her hospital. And so today she will talk about 10 years of clinical research and experience in pediatric PTSD following mass trauma that they lived through, and they still care for the patients. I was invited there, visited Nice last year, worked together with her group, and it was very impressive to see how they keep contact and how a complete city was transformed by what had happened to them just in one day. Yeah, so if you compare that to the war situation, we can imagine what that means for you. Florence is a highly decorated researcher. She has the National Order of Merit, the Ordre pour le Mérite. She's a Knight of the Legion of Honor, la Légion d'honneur, and a Silver Eagle of the Order of the City of Nice. So we have really a very impressive speaker, and I will not steal more of her time and just give her the floor to present to you. Thank you, Florence, for coming and for presenting here. The floor is yours.
Дякую, Йорг. Тоді прошу спікерку і слайди на екран, а нас всіх можна прибрати з екрану. Дякую.
Thank you. Thank you very much, Jörg, for your words. And thank you also to the colleagues in Ukraine. And I really I try to share what you can feel today. So I'm really honored to be here with you today. I will today present the Nice Pediatric Psychotrauma Center. And this center, as said Jörg, has a very specific origin. It was created directly in the aftermath of this mass traumatic event, the terrorist attack that took place on July 14, 2016 on the Promenade des Anglais in Nice. Indeed, 86 people were killed this day, including 50 children. In this talk, I will first share some general information about child trauma and PTSD. Then I will present the main finding from our research conducted after the terrorist attack in Nice. I want to begin with a broader point. Collective disasters and also traumatic events in private life are increasing significantly, and they disproportionately affect the most vulnerable populations. The data show that about 2/3 of children under 16 are exposed to at least one potentially traumatic event. Around 60% of the world's population will experience a traumatic event at some point in life. Among those, roughly 70% will be resilient. And that is a very good news. But the challenging reality is that about 30% will develop post-traumatic stress disorders, and that's a very bad news. On this slide, you can see the key concepts that help us to understand collective violence today. First, the degree of exposure. The more directly a child is exposed, the higher the risk of developing post-traumatic distress disorder. But, as we will see during this talk, nothing is that simple. It will be naive to think it's such a linear way. Cumulative exposure is also a major factor that we must always look for to understand, to treat, and to identify which patients are at higher risk. The child's development level is also essential to consider. The critical role of traumatic and loss reminders. And this brings us to an important societal question about anniversaries and ceremonies, which often punctuate the aftermath of collective disasters. Then there are also the interactions between grief and trauma. The more bereavement there is, the higher the risk of PTSD. Prior experiences, both trauma and loss, play a critical role. Today, we recognize how important they are in shaping traumatic reminders and loss reminders. And of course, the most important factor, and the one we can act on, is the strength of the social protective shield around the child. For me, it's really a key point of my experience since 10 years now with these victims. Child psychotrauma must be understood through a global lens today. It impacts the perception of the self, the world, and the future. It impacts the ability to form secure attachments. It affects the capacity to trust others. It damages our deep sense of safety. It impacts the ability to cope with life changes. It impacts overall social and emotional development. And importantly, it can profoundly change the way the brain functions. It raises a major issue for neurodevelopmental milestones. Psychotrauma also affects a child's development and learning. It can lead to difficulties with concentration and memory, creating a form of ADHD-like profiles. To discuss, thinking can become less flexible. Problem solving can become more difficult, with issues around focus, information processing, and organization, including difficulty learning new information. Collective psychotrauma in children also produce emotional manifestation in several ways. Anger, which is very frequent to my experience with the children. Opposition to adult instructions. Mistrust. Mistrust is often understood by professionals. Sleep difficulties, irritability and mood swings, avoidance, which is really frequent, difficulties with concentration and attention, often linked to stress and worry. We also see over-planning, meaning the child constantly tries to control everything happening around them. And above all, we see a negative perception of the world, of peers, and of the child's own emotion. You likely know this, but here's a brief reminder of PTSD symptoms. PTSD is a consequence of trauma, and it is the most studied consequence. For PTSD to occur, you know that you must have been in face of an event in which the person perceived or believed that they were going to die. PTSD is structured around 4 main components, forming a symptom square. When this symptom pattern lasts more than 1 month, we can speak on PTSD. Between 3 days and 1 month, we speak of acute stress disorder. So the 4 main symptom clusters are negative alteration in cognition and mood, alteration in arousal and reactivity with hyperreactivity, 3, re-experiencing symptoms, the beating heart of PTSD in children, which can affect children at any time of day and deeply impair their quality of life. Avoidance symptoms, often very clear at this age of life also. For example, after July 14, many families and children needed several years before they could return to the site of the attacks. Because it occurred on the Promenade des Anglais, the very center of the city, this avoidance significantly disrupted daily life of all this population. Others saw their activity radius shrink dramatically, going out far less and staying much more at home. But what are the pediatric specificity of PTSD? All children from 0 to 18 suffer from PTSD. What is characteristic and also typical of child psychiatry is that many other disorders can be associated with PTSD, which
Ross, you are muted. You are muted at the moment.
Is that better? I don't know what's happening.
It's okay now, yeah.
Yeah, okay. When do you lost the connection?
Just when you started that slide, pediatric
Okay.
specificities of
So the
PTSD.
specificity of pediatric PTSD.
Yeah.
I do
Yeah.
not know what's happened. What are the pediatric specificity of PTSD? All children from 0 to 18 can suffer from PTSD, and that's very important to underline. What is characteristic and also typical of child psychiatry in general is that many other disorders can be associated with PTSD in children. And that complicates clinical work. Anxiety disorders are very common. Sleep disorders are also a major public health issue after trauma, ADHD, and major depressive disorder, which can lead to very severe mood deterioration. As you can see, pediatric PTSD is a highly complex phenomenon. Unfortunately, the medium and long-term consequences of collective disasters in pediatric population are still poorly known, and I could say also the consequences of ongoing trauma on pediatric population, like you are living in Ukraine. There are no studies beyond 2 years, and we lack data on medium and long-term trajectories. On this slide, I want to focus on what is truly specific and clinically important in pediatric PTSD, recognizing how PTSD consequences shape a child's everyday life. A child may develop school difficulties and sometimes even difficulty attending school, especially because avoidance symptoms can generalize. School can become associated with reminders of the event, separation with the parents, crowds, noise, or simply fear of what might happen next. For example, I treat a 6-year-old girl who was exposed during the attack. She and her mother were trapped under the truck. Her mother suffered severe injuries. Afterward, at school, the child could sometimes be suddenly taken over by flashbacks. For instance, if she saw a truck entering the schoolyard, it could trigger intense distress, behavioral reactions, and clear regression. These episodes became so severe that they eventually prevented her from attending school. PTSD also affects a child's capacity to integrate socially because the child is under repeated emotional and cognitive strain, intrusive memories, hypervigilance, sleep disruption, and attention problems. Over time, this can lead to withdrawal, misunderstandings with peers, and increased isolation. Loneliness is a major problem of PTSD in children. We also frequently observe relationship difficulties, not only with peers, but also with family and with teachers. And these relation consequences can be deeply harmful because children develop full relationships. Another essential point is the family system. Conflicts with siblings and broader family difficulties are often intensified by the fact that in collective trauma, parents are frequently affected as well. This is fundamental to understand mass trauma. One of the strongest risk factors is when we see a close correlation between the child's symptom and the parent's condition. When both are impacted, the risk of significant and persistent PTSD in the child increases substantially. Finally, we must take into account that access to care is different for children than for adults. A child's pathway to care depends on parents, who are often themselves exhausted or traumatized. This creates a real challenge for health care professionals. Helping children reach care when practical barriers exist. For example, when school schedules dominate family life and when care may be perceived as competing with school rather than supporting it. In children under 12, we often observe difficulties distinguish reality from fiction. This complicates for us the diagnosis of PTSD. In younger, preverbal children, what's happened? PTSD particularly affect early relationships with the parents, with a high risk for affective, emotional, and cognitive development. But it is very difficult to recognize symptoms, and especially their specificity. Re-experiencing can appear in a sensory way. For example, a very young child will stutters at the smallest noise. Some children also have difficulties integrating perception and sensation, including in relation to music. Any therapy that works through sensations can be extremely beneficial for these children. Finally, we do not forget pregnant women. There are also specific issues. We should not forget that a child, even in the womb, can be affected by trauma experienced by the mother. Studies conducted after the 9/11 attack in New York suggested impacts such as reduced head circumference in children born afterward, changes in stress hormone regulation systems, and the potential risk of lower IQ in the long term. All of this needs to be confirmed through further studies and will require a structured research program to truly understand what happens in very young children. This is a very particular slide. I would like to show you an example from a psychotherapy I conduct with a 4-year-old boy who was exposed during the attack in July 14, 2016. On this slide, you can see a series of sequences over a long time from a psychotherapy with the child. I am showing this slide because it illustrates a phenomenon we often observe in young children after trauma, what we call repetitive or traumatic play. I conduct a classic psychodynamic psychotherapy with the child, not cognitive behavioral therapy of trauma-focused therapy. And I met with the child very regularly, once a week at least, during more than 1 year. This 4-year-old boy was at the scene with his father. The father developed an acute dissociation reaction during the attack, and in the immediate aftermath of the attack, he became completely disconnected from the world. During the chaos, the father held the child tightly against him as he walked along the Promenade des Anglais, searching for a friend who had died, without fully realizing that the child was right there with him. You can see here that the child used small objects available in my office, small wooden toys, and small symbolic pieces representing characters. And over long session, long time, each time he repeated the same scenario. A family lying on a white table replaying the traumatic scene. We had to wait more than 1 year for the child to begin bringing a fire truck to the table, the first sign of rescue. Then it was not until a couple of months that the child allowed the rescue team to take the family to a hospital represented here by a form. This shows the long, necessary therapeutic work that must take place between the therapist and the child, so that the child can gradually reconstruct something safe and protective for the family and for himself. What I want to say, and the message, the most important message, I know that it is very important today to have focused psychotrauma therapy and to have therapy for a large number of victims, but we have to never forget that it could take time for a child to recover. On this slide, on these slides, I wanted to talk about parents' experiences in the context of mass trauma. It's just a summary. There is a lot to say, but it's important to underline some key points. Surprisingly, many parents feel guilt and shame, both about being victims themselves and about the fact that their children were victims. They often feel they failed to protect their child. They may experience a strong sense of injustice, anger, and helplessness. Many also feel incompetence as parents, believing they were unable to keep their children safe. As a result, some shift toward overprotective attitudes with persistent fear about what could happen to their child. For them, it can be very difficult to regain a confident parental stance. For example, decision-making can become extremely difficult. Parents may come to us asking for guidance of everyday choice. What should we do for the holidays? Should we get a dog? Is this decision good for my child? They often need reassurance and support to rebuild their capacity to decide and to lead. A reason why, with my team, we develop guidance group for parents. In addition, many parents may develop PTSD themselves, along with other associated difficulties. This clearly becomes an additional risk factor for the child's development. So quickly, because I soon speak about that in the second slide, it's very important to understand psychotrauma and PTSD in the sense of being modulated by risk factors. But I can say that the most interesting is also to study protective factors, because we can strengthen them, and this helps both children and parents. The first and most important protective factor is the quality of family relationships. This is with family support and sometimes family therapy can have a strong positive impact on a child's recovery. A good relationship with teachers at school also matters a lot, as well as supportive relationships with peers, both inside and outside school. Participation in activity outside school is another important part of our work. It helps children reconnect with normal life, build confidence, and feel safe again. Other protective factors include good social skills, self-esteem, and the ability to ask for help. For many victims, asking for help is really a challenge, and it's difficult because of the guilt and the shame they feel. So we need to make this easier and more acceptable. And finally, we should also pay attention to substance abuse especially in adolescence, because it can worsen symptoms and slow recovery. Moreover, and it's not on the slide, but I see that every day is also the access to social networks such as TikTok or Instagram, where they can also facing again some trauma. Okay, now I would like to share, I don't know what, you can see all the slide. Yeah, okay. I would like to share our experience with my team after the July 14, 2016 truck attack in Nice, both as clinicians and as researchers. To begin, we will speak about the first night and the first 15 days after the attack. During the first night and the first 2 weeks after the attack, our pediatric hospital was in the immediate area, only about 200 meters from the site. Here you see the child looking from a window to the Promenade des Anglais, and she is looking to the policemen and the people coming in the morning of the attack. So you see it was very close. So we had to manage a massive influx of victims, and the hospital was absolutely not prepared, as we do not live in a context of war. We live on the Côte d'Azur, and it was really unusual for us. It was really a threat. On the first night, we did not yet have an organized medical triage process. The entire hospital was affected by the attack, and every pediatric department was involved. Local sector-based child psychiatry teams, as well as the university child psychiatry team at Fondation Lanval, were mobilized. Very quickly, a new way of working emerged. An emergency psychotrauma approach became central in the first phase of the response. During the first 15 days after the attack, we had to run an emergency response for psychological care alongside the medical response. In France, we have a specific system called the Emergency Medical and Psychological Unit. They were present on the seat 2 days after the attack and came to help us day to day. It has existed for more than 20 years, this system. After a mass trauma, volunteer professionals are deployed very quickly, usually for a period ranging from 2 days to 2 weeks. Teams include psychologists, psychiatrists, nurses, and other mental health professionals. In Nice, it was a real challenge to respond to a very large number of psychological casualties. This was the first pediatric emergency medical and psychological unit in France, created after a terrorist attack. A large number of patients arrived at the pediatric emergency department, and at first there was no structured medical triage. The child psychiatry teams had 3 main goals: to reassure, to help families regain a sense of stability, and to treat acute stress reactions, including peri-traumatic dissociation. We also had a very difficult and important task: notifying families of deaths. In parallel, we provide child and adolescent psychiatric support for children and families who were hospitalized in surgery and in intensive care. And as early as possible, we had to organize a response for psychological casualties and for the highly anxious relatives, including parents, siblings, grandparents, cousins. On this graph, you can see the number of consultations for children and adolescents in the pediatric emergency medical and psychological unit between July 15 and July 28. As you can see on the graph, we had an average of 70 consultations per day with peaks in the first week after the attack, especially around 18 and 19 of July. A large number of professionals contributed during this period from July 15 to July 28. 39 psychologists, 36 psychiatrists, 31 nurses, 7 head nurses, 25 secretaries, and they were very important. And social workers also have a key roles when it happens something like that. In total, 146 people worked during these 2 weeks after the attack. On January 1, 2017, the Pediatric Psychotrauma Center was created in Nice, specifically dedicated to the victim of the attack. So we were 4 people to manage that. Today we are more than 30 people to work all together in the Pediatric Psychotrauma Center. So the Nice Pediatric Psychotrauma Center has now seen more than 8,000 outpatients since 2018. This center is specifically dedicated to children and their families. We offer an individual practical care pathway delivered by professionals who are all trained in pediatric psychotrauma. And this is a very important point to underline. The formation of health professional to psychotrauma is a very important point. This allows us to provide trauma-focused psychotherapy and coordinated follow-up over time. Since 2018, we have been part of the French national network of regional psychotrauma. And the last, but not the least, the center also includes a clinical research unit linked to University Côte d'Azur. What are the missions of the Nice Pediatric Psychotrauma Center? First, clinical care and clinical research are closely linked in our day-to-day work. We use a range of evidence-based targeted psychotherapies for children and families. At the same time, we evaluate and validate new treatments. This includes new psychotherapy approaches and also pharmacological treatments when needed. Since 2020, we also had a mobile psychotrauma team. This means trained professionals can go directly to the family's home or meet them close to home to reduce barriers to care. And since 2019, we also contributed to European Commission missions working on trauma contexts linked to terrorism, migration, and more recently, the war in Ukraine. We launched an ongoing research program based on heart therapy with some of your colleagues, with two parallel groups, one in Kyiv and another one in Nice. The group works with Ukrainian refugee families in Nice. In Kyiv, the group supports children and mothers who are living directly under bombing. We also participate to a formation program for Ukrainian colleagues supported by the organization Superhumans and the Ministry of Foreign Affairs. On this table, you can see our consultation for 2017 to 2019. Okay? Okay. On this table, you can see our consultation for 2017 to 2019. In 2017, many visits were linked to the terrorist attack. In 2018, these visits begin to decrease, while consultation for other kind of trauma increased. By 2019, the trend is clear. Fewer new patients linked to the attack, and many more other consultations for other types of trauma. On this graph, you can see follow-up patients for 2017 to 2019. Follow-up linked to the attack, the blue line, continued over time, which is expected. But after 2018, follow-up for other types of trauma increased sharply, showing that the center progressively became a broader regional resource for pediatric psychotrauma. The main diagnosis collected for the 866 children was PTSD, but we also saw acute stress disorder, anxiety disorders, neurodevelopmental disorder linked or before the trauma event. It's a discussion. A major depressive disorder. Comorbidities was very common, about more than 67% of patients and at least one additional diagnosis, especially sleep disorders. To summarize, in the first 3 years, 71% of patients had PTSD diagnosis and 9% had acute stress disorder. These rates are slightly higher than what is often reported in literature, possibly because of the specific context of a terrorist attack and our referral pathway. Comorbidities were frequent, especially sleep disorders like nightmares and difficulty falling asleep, and severe comorbidity often makes PTSD symptoms stronger and longer lasting. On this slide, the graph shows the percentage of children by type of trauma, except the attack. The most frequent type of trauma was road traffic accident. Then we see mourning, migration, physical and sexual assault. But what are the key points of this first resource? We can say that a dedicated center for children after a mass traumatic event is an important tool for secondary prevention of pediatric PTSD. And it is needed for many years, not only in the first months. Even today, we still receive new requests related to the long-term aftermath of July 14, 2016, including relapse and delayed difficulties. In adolescence, we also see complex clinical situations, for example, with eating disorders, where the link with the attack is not always clear to the family at first. This is an important point for clinicians to keep in mind. Another key message is that building a specialized level 3 center must not make us forget the importance of level 1 and level 2. The front line matters. Schools, primary care, community services, and early support. Finally, our experience suggests that a center like the Nice Pediatric Psychotrauma Center can be part of a broader response to a major societal risk that we have to face today all around the world is cumulative trauma over time and ongoing trauma. All these results raise important questions. First, there is a question of indications. Which children should be referred to a specialized center? How do we adapt our care depending on the type of trauma? For example, single event trauma versus repeated trauma? And what about complex trauma, cumulative trauma over time, and ongoing trauma? A second question is about systems and coordination. Many actors are involved. Public authorities, institutions, local services, the emergency medical and psychological unit, and also the justice system. So we must ask, what is the role of a center like ours in this wider system? And are we in some way a safeguard that supports public response and public responsibility? The third key question is the risk of vicarious trauma for professionals working in such a center. Protecting teams is essential if we want this work to be sustainable. And finally, we must look forward today. What is the right response to the growing societal risk of ongoing and cumulative trauma? Now, I have 10 minutes or 15 minutes. Is that okay?
10 minutes is okay. Yes, Florence.
It's okay. So I think it will be enough for the last part of my talk. So now, let me move to research program 47 and share our preliminary results. So the methodology of research program was published in Frontiers in Psychiatry in 2019, so you can easily consult this publication online. Research program 47 is a clinical research program for cues on children and adolescents exposed to a single terrorist event, which is a very particular population of children and their family. With our experience today, I can say one key message very clearly. It is essential to develop research activities in parallel with clinical care. Treating children and supporting families is the priority, of course, but research, it what allows us to improve care, measure outcome, and be better prepared for future events. Program 14.7 is a cohort study of children who were under 18 at the time of the attack, as well as their parents who were also exposed. It is a long-term clinical follow-up study, now extending to more than 5 years after the attack. To date, around 900 participants have been included. Children aged 0 to 18 on the day of the attack and their parents. So we divide the children into 3 age groups based on neurodevelopmental consideration and the assessment tools we used. 0 to 6, 7 to 12, and 30 to 18. For this program, we use a set of assessment tools. All these tools were translated from English into French using a strict process, double translation, and then validation of the French version. This was one of our first tasks. It is not glamorous, I can say, not sexy, but it is essential for the clinical and research community. So in this program, we also assess the child's subjective fear. We will talk about this, this assessment and the results, very interesting. The type of injury, the number of traumatic events, the somatic symptom associated, the type of emerging care received, and the follow-up care. PTSD was assessed systematically using the gold standard interview, which is a CAPS adapted to age. We also carry out age-appropriate structured diagnostic assessments and standardized cognitive testing using tools adapted to each age group, with versions for preschool children, school-age children and adolescents, and also adults. For parents, we use PCL5 style for anxiety, HDRS for mood and depressive symptoms. Now, I would like to share some preliminary results we published in JAMA Open based on 271 consecutive outpatients seen in our clinic. So these results are available easy on internet. The mean age was 9 years old and 31% were boys. Among these 271 children, 77% had experienced at least one previous traumatic event. However, none of these prior events involved child abuse or sexual abuse. So, on this slide, we focused on comorbidity, meaning the diagnosis associated with PTSD. On average, we found about 2.4 associated diagnoses per child, and this is really consistent across all age groups. Overall, 62% of the whole group met criteria for PTSD. 79% anxiety disorders, including 55 specific phobias and 30% separation anxiety. On the left of the slide, you can see this graph showing the rates across the 3 different age groups for PTSD, anxiety disorders, major depressive disorder, impulse control disorder, and ADHD. This slide is particularly interesting, I guess, because it focused on the interest of main pre-traumatic factors, sex and age. What we find is that there were no significant differences by age or sex across the 3 subgroups for the D5 diagnosis, PTSD diagnosis. In contrast, for anxiety disorders, we find a significant association with age across the three groups. We see a similar age pattern for MDD and also for conduct-related disorders, including intermittent explosive disorders and oppositional defiant disorder, as well as for ADHD. One main hypothesis from this result after a mass trauma event such as a terrorist attack, PTSD in pediatric population may follow a relatively stable pattern, while other associated disorders vary more with developmental stage. On this slide, you can see briefly, because it's an ancillary study from my team, also on pediatric population. We wanted to conduct the study about somatic symptoms associated with PTSD in psychotrauma. This was because we are used to work with pediatricians and we work into a pediatric hospital, so we are used to collect somatic symptoms. And what we find is very interesting for clinicians working every day with children. The key result is that cumulative trauma, first the key result is that cumulative trauma, meaning more than 2 traumatic events, were associated with higher level of somatization in children. In our regression model, the combination of headache, palpitation, nausea, fatigue, and sleep disturbances explains 6.5% of the variance in PTSD severity. So this is a clinical message, very simple. In young people exposed to trauma, somatic symptoms are common and they are more marked when PTSD is present. So what should we screen for in first-line settings, such as pediatrics, school medicine, and emergency care? Key red flags include headache, palpitation, nausea, fatigue, and sleep problems, especially when symptoms are multiple, persistent, and associated with distress or functional impairment. The broader implication is that we need stronger integrated pathway between pediatrics and mental health, early detection, coordinated care, psychoeducation, trauma-focused therapy when indicated, and specific support for sleep and pain management. This is in another word, I think, but we can hope. Now, I would like to focus on a key topic, the risk factor associated with PTSD in children exposed to the terrorist attack in Nice that we have published in the British Journal of Psychiatry in September 2025. So, as you know, the risk of PTSD is influenced by several types of factors, pre-traumatic, traumatic, and post-traumatic factor. We soon speak about that at the beginning of the talk. So you have the slide and you can read the slide after the talk. I just want to focus on the research papers of my friend Eva Lizig, who is professor in Melbourne and who lead very interesting researches on this topic. So now our results is interesting for you also. On this slide, I present the main results of our study on the risk factor in children exposed to this terrorist attack. So as previously, we assessed the 271 children directly exposed to the attack. What is particularly interesting in our sample is that several pre-trauma factors that are usually seen as predictors of PTSD did not predict PTSD in our children. This includes age, sex, we see before, sex assigned at birth, and cognitive functioning also. In contrast, two trauma-related factors clearly emerge as significant predictors of PTSD. The intensity of subjective fear during the event, the lifetime number of traumatic events, meaning cumulative trauma, which is a very important field today. Finally, we also identified two important post-traumatic factors: maternal symptoms, including anxiety, depression, and PTSD, and child somatic symptoms. We also found that comorbid diagnosis played a crucial role in the child PTSD. So you can see the results on this table, and you will find all the table on the paper published in the British Journal, easy to reach. But how can we interpret all these findings? First, the lack of effect of pre-trauma factor may reflect the very high level of exposure of these children in this event. Intense life threat and extreme conditions. In such a context, these extreme stressors may override the usual differences related to age, sex, or cognitive level that are often observed in other trauma settings. Second, the role of subjective fear and cumulative trauma is fully consistent with the pediatric literature. These are major determinants of PTSD risk in children. Third, the mother role is central. Maternal anxiety, depression, and PTSD symptoms are strongly associated with the child's PTSD. We can hypothesize several mechanisms, including family climate, social learning, and shared biopsychosocial vulnerability. Finally, somatic symptoms and comorbidity may reflect a more severe clinical trajectory. This supports systematic screening for somatic symptoms, anxiety disorders, impulse control disorder, ADHD, and other common comorbidities in this population. To summarize, subjective fear, the lifetime number of traumatic events, and maternal symptoms emerge as significant predictors of PTSD in children. This finding helps us better identify children and adolescents at high risk of developing PTSD after a terrorist attack. They open the door to more precise and more personalized care in the future and across countries. The fact that the number of traumatic events predicts future PTSD should also be a wake-up call for policymakers. It highlights the urgent need for focused, coordinated strategy to prevent pediatric PTSD. To close this talk, I would like to share the conclusion I have reached today. Of course, tomorrow, new conclusions may emerge, and they may refine or even change what I'm saying now. But several key points already stand out. They can help us build a stronger and more effective response to post-traumatic stress in children and adolescents. We must raise awareness of PTSD risks after collective trauma. Dedicated centers for children and their parents have clear value and should be supported over the long term. We need stronger epidemiological study, and we need to validate and improve our tools and care pathways. We must expand access to evidence-based trauma-focused psychotherapies. At the same time, we must strengthen level 1 and level 2 prevention by working closely with first-line professionals and schools. This is a major societal challenge. Finally, harmonizing pediatric PTSD research across European countries is essential, and it remains a real challenge. And if I had a dream, it would be to help change our world from this to that. Before the discussion, I would like to let you know that you are welcome to join us in Nice on June 4 and 5, 2026 for the Congress of the French Society of Child and Adolescent Psychiatry focused on child psychiatry and psychotrauma. Thank you for your attention, and I also want to express my full solidarity with colleagues who are working in the context of war and ongoing trauma. And now I'm ready to take your question about what I have presented today. Thank you again very warmly. Thank you.
Дуже дякуємо, Флоренс, дуже дякуємо, Йорг, що ви залишились наприкінець цього ефіру. Зараз я буду зачитувати питання. Хвильку. Я тут листаю до початку цих питань, бо їх доволі багато. Зараз, хвильку. Так. Пані Альбіна Кайдалова питає. Достатньо інших проявів симптомів у дітей, особливо якщо це накладається на вікову кризу і соціальні проблеми, схожі з ПТСР. Наприклад, був випадок, коли після прильоту ракети мама з дитиною виїхали за кордон, через деякий час почались проблеми у дитини, звернулись до психотерапевта ПТСР. Терапія нічого не давала, змінили фахівця, з'ясували, що у дитини не ПТСР, а проблеми адаптації за кордоном і небажання там жити. Питання таке, чи насправді стільки дітей проявляють ПТСР, як про нього зараз говорять?
Could you just repeat clearly the question, please?
Я тоді парафразую питання для перекладачів. Чи настільки багато ПТСРу, наскільки люди, наприклад, в Україні під час війни собі це уявляють?
It's not so easy to answer to your question. Yes, a lot of people could have PTSD, but it's not so simple. I think PTSD is a core symptoms, and it's very important to assess PTSD in children, also the parents, also the adults. But it doesn't mean that all people will have PTSD, as I say at the beginning of my conference. more than 70% of people will be resilient. And there is a study driven by my friend Michael in Netherlands. And what does he find? He finds that in the country which are more prepared and in the country were usually used to have a lot of psychotrauma, mass trauma, they are more resilient than the other one. That a country like France or the United States are more vulnerable that country with a high degree of mass trauma every day. But it's just a scientific photography. Huh? I do not want to discuss from political implication of such discovery. And also in the papers, there is some methodological issue we can discuss. So it's a difficult question, and we cannot have a simple answer to that. But you can go to this publication. It's very important of a meta-analysis of the rate of PTSD in different countries, in Africa, in the United States, in Europe. And you see that it's different with some factors.
Пані Оксана Шевченко питає, які існують доказові методи терапії PTSD у дітей?
Up to today, there is some treatment which are evidence-based for children PTSD, which are cognitive behavior psychotherapy, of course. That I think it's a level A of proof. EMDR, no, at the degree of proof. And in my team, we have two studies on to validate EMDR specifically in young children, because up to today there is no validation for EMDR in young children. And different types of focused trauma therapy, so wet therapy, and also re-massage therapy.
Окей. Зараз хвильку я дивлюсь наступне питання. Так. Зараз. Нас питають, чи можна нас подивитись не в трансляції. Так, буде записи українською і англійською мовою. Олена Кудаєва питає, які методи діагностики ви використовуєте? Ви казали, що є якісь тести з віковою специфікою. І чи ці тести є валідними, і чи є вони у відкритому доступі?
Yes, for example, in French, they are all available on the site of the French Society and on the site of the Center for Research and in Psychotrauma in France. I could give you the link, but it's French. And you have the link to the American publication. Main of the tools are American. A lot of were validated by the team of PNOS in the United States. Sorry. Also very interesting, you can read the book of Sheringa on very early age children who met the criteria of PTSD, and you will find a specific focused therapy for young children and also specific tools. But I don't know in Germany, Jörg, what is the program with tools to assess PTSD. For France, we have done this job, and you can find online all this assessment. And to my knowledge, some of these assessments are translated in Ukrainian language.
Yes, they
Пані
are.
Карп...
They are often posted on the websites. So I think they are easily accessible.
Пані Карпенко Ольга питає, з огляду на досвід роботи з дітьми після масових травматичних подій, які ранні ознаки у дітей, що пережили війну, обстріли або вимушене переміщення, мають стати для кризових психологів сигналом до негайного спеціалізованого втручання, а не лише психологічної першої допомоги?
Yes, it's a very important question, and what I try to say during all this talk. First, I will respond that it's very important as professional in child psychiatry or health mental professional to be trained to child psychotrauma. As you see, the first symptom as the symptom of acute stress. And the symptom of acute stress can have several different forms depending on the developmental stage of the children. For at the early stage of development, this stress can have a very different way for clinician, and it's not so easy to define. It could be a child that cry a lot, much more than usual, but it could also be a child. I have seen a lot of children who were like autistic children, totally in a form of retrait, no more speaking, with no communication with their parents, and still staying with no movement. So they could be very different. So that's why we try to study a closed door, which are somatic symptoms. So somatic symptoms seems to be a very important door to child PTSD. And so it's very easy when you have a mass trauma and children are coming to the emergency, pediatric emergency, to make the red flags to the children who have a combination of symptoms, of somatic symptoms, and more specifically headaches, nausea, fatigue, sleep disturbance. Sleep disturbance is a very important clinical signs of the beginning of psychotrauma in children.
Excuse me, may I add one thing that is quite important from my perspective? When we talk about early symptoms, we are just after a trauma, we are not sure what kind of disorder kids will develop. We see an immediate stress reactions, often with somatic symptoms as you described, but we have different courses. We have some children with high problems all over the time, and they will develop a disorder. In other children, the curve will go down and they will go back to normal and will prove to be resilient after 6 months. Others seem to be coping perfectly, very well, and develop symptoms over time after 6 months. And then you have the really resilient children who show nothing at the beginning and are fine after 6 months. So my main message would be, don't predict too much what happens, just observe. Give solace at the moment when you see the stress reactions, to calm them down, to feel them, to make them feel comfortable. Keep daily routines, don't make too many exceptions, because children need rules, need to go to bed, need daily routines. And then observe the children over time. Sorry to interrupt, but I think that's very important to not to overreact at the beginning, but really to observe the children and the course, because whether it becomes PTSD or not, you only see after a certain time. Yeah.
Yes, I agree.
До цього ж є питання від пані Порохня Ліана. Якщо вагітна жінка стала учасником травмуючої події, чи обов'язково у новонародженої дитини будуть симптоми ПТСР, і на які маркери необхідно зважати, що необхідно робити, щоб допомогти?
Good question. It's absolutely not a necessity that the child will have PTSD. And up to today, we do not know exactly the percentage of children born in an aftermath of mass trauma. But as Jörg underlined for the previous question, we have to keep an eye on these young children, and it depends on the capacity of each country to develop prevention for these very young children. For example, in our research team, we have a research program for babies with AI to manage the capacity on videotapes, family videotapes, to detect preventively first signs of difficulty of communication between the young baby and the parents. That could help to focus very early on some children. But this only research, and I have not the possibility to answer clearly today to your question for the young babies. Perhaps you can have another answer to this question. I don't know, but...
Пані Оксана Міхняк пише: «Дякую вам за те, що поділились цим досвідом. Було цінно почути, як саме надавалась допомога в реальних кризових умовах». І питання: чи аналізували ви дітей, які не розвинули ПТСР? Які фактори резильєнтності були? Ви працювали переважно з тими, хто сам звернувся, чи проводили скринінги серед тих, хто був свідком теракту? Яка частка дітей потребувала медикаментозного лікування?
There is many questions. First question, unfortunately, with the French government, we were not able to manage the assessment in general population, which was my first goal. So unfortunately, up to today, I have no data in general population in Nice for the resilient, and all our studies are in clinical population. So that's why I insist of the necessity to have at a European level a system to harmonize research after a mass trauma event or ongoing trauma. And if we harmonize, if research, that will be a very long work, then we focused on the necessity to assess acute stress symptoms and PTSD in general population and not only on clinical population, to learn on the course of PTSD. And as Jörg underlined, you can have some children, and also we met that in our experience, who had new symptoms long time after the attack. So a second point is that it's very important to lead research for a long time on PTSD, to learn on the course of this disease for children. I think there was another question, but I do not remember. Could you repeat? I think for pharmacological treatment, perhaps, or something like that.
Яка частка дітей потребувала медикаментозного лікування?
To my knowledge, there is no pharmacological treatment with proof for children up to today. So there is some researches. In our team, we have researches for sleep disturbance with melatonin, of course, and we use it usually in clinical practice. Melatonin for sleep disorders with children with PTSD and after traumatic event. It helps a lot. But in literature, prazosin is also mentioned, but not very. The studies are not so interesting, it seems. And in the States, they begin to use and to study psychodysliptic medication, but it's not legal in Europe, so we have no data on these medications. The first line is focus psychotherapy for children, focus trauma psychotherapy. What we called developed for PTSD in children after mass trauma and in the context of ongoing war could be a very quick focused trauma psychotherapy and type of psychotherapy very easy to use for every types of health mental professional.
Інакше тут питання є в нас чатику. Чи рекомендуєте використання brain spotting and EMDR при ПТСР у дітей?
Yes. EMDR seems to work very well in my experience for children. But you need good professional and very well trained. So it's a long training for EMDR.
Від пані Світлани.
Від
пані Світлани питання: мелатонін чи можна в дитячому віці?
Melatonin you can use in children. In France, we have some forms that are dedicated to children, specifically for autism disorder, but you can use this form for PTSD, and it's very useful and it helps a lot of children for sleep disturbances. But it's not enough, but it's still very convenient.
Угу. Пані Надія Орищак питає, як спілкуватися з закритою формою ПТСР з підлітками, батьки яких були у полоні?
I have not experience of such difficulties, but we have the experience to talk with children mourning for their parents. And we met a lot of children in mourning after the attack or after other type of trauma. And there is not really papers on that. So first, you need very good professional, very trained. It's not possible to face professionals who are not trained to such important difficulties. Adolescents often denied the reality and try to and have a very, very important rage and anger against the other when there is such important difficulties in their life. So they need to be listened, they need to be understood, they need to be reassured. And the most important reassurance for the adolescents is to have structured adults that they can trust to move on after these disasters. And that could be found in the society, that could be health professional, and that could be also parents, close parents, that we have to support to be structured parents for the adolescents.
І останнє питання на сьогоднішній вечір від пана Владислава Бардадіма. З якого методу починаєте роботу з дітьми? Арт-терапія, сугестивна терапія, КПТ. Які інструменти і вправи, на вашу думку, є найдієвішими?
For art therapy, that's right?
Арт-терапія, сугестивна терапія, КПТ-терапія.
CBT therapy, of course, but art therapy is a very interesting concept because, of course, CBT is the gold standard, but not every people are used to. It's really important question because now we have to face of a very important influx of children suffering for psychotrauma in our context, in globalized context of the world. So we do not have enough professional trained for CBT psychotherapy. And I guess that something like culture and art in our society could fight against the negativity that and the impacts of PTSD after mass trauma and ongoing trauma. But it's also, there is a lot of researches on this field, and Mondial Organization have published a lot of papers on this field that you can read online on the website of the Mondial Organization about this question. More than 129 papers, I guess, are published on this question.
В нас багато дуже таких коментарів, дуже позитивних, з подяками до пана Йорга Фегерта і до пані Флоренс, і до перекладачів за сьогоднішній вебінар. І нас було багато людей на сьогоднішньому вебінарі. Я всім дуже дякую, що ви, незважаючи на те, що нема світла, дуже холодно, і великі обстріли, особливо в Одесі, наприклад, були останнім часом, і до того в Києві. Я вам всім дуже дякую за те, що ви прийшли на цей вебінар. І дуже дякую пану Йоргу за те, що він все це організовує і не втомлюється це організовувати. І дуже дякуємо пані Флоренс, що вона в свій неробочий час ввечері погодилась поговорити з нами. Всім вам дуже-дуже дякуємо. І на сьогодні закриваємо наше навчання. Дякую вам всім.
Thank you. Bye. Bye-bye.
Thank you all and keep safe. Bye-bye.
Bye.
Take care.